Good morning. Okay, it's 4:34. We shall continue. इसका charging देखना है अभी. Charge for इसका भी बैटरी है. Good morning. Aditi, hi, Sarthak. And just get the charger. Good morning, Moana. Good morning, Ru. Hi, Sanya. Now you feel fresh. Good. Dehydrated. I have an exam, yes. Chal, I only do the important questions, I think. आराम से जाना है. I'm well prepared. No stress. Today go with a good mindset. And मस्त आज 4 घंटे अच्छे से I'll study and do. So at least I'll go with a good positive mindset. And I know my stuff. I can do it. आज no compromise on quality. Yes, thank you guys. Yes, that's the mindset. Let's go. No stress. Yes. Okay. CVS. We'll start with the LQs directly. Cardiac cycle तो है नहीं. Coronary circulation. चलो. Let's go. You're doing the main questions. You know the basic idea of everything. So no stress. And you can easily handle it by just reading the main questions. And bhalani enough. More than enough. Don't doubt yourself. New system. You know physio is your forte. Coronary, fast. 546 coronary आ सकता है LAQ. Okay. Coronary circulation में you have to describe physiology, anatomy of coronary circulation, physiological anatomy, factors affecting coronary circulation, special features, and angina pectoris. Now describing the features of anatomy of coronary blood supply. Heart is supplied by left and right coronary end arteries. Left coronary artery supplies anterior and lateral position of the left ventricle. of the left ventricle. Right coronary artery supplies most of the right ventricle as well as the posterior part of the left ventricle. In 20% of people, left artery, and in 50% the right coronary artery predominates. In 50% of people, right coronary artery predominates. Left coronary artery supplies the left ventricle and the anterior lateral. Right coronary artery supplies right ventricle and some parts of left ventricle. From left ventricles by way of coronary sinus, and from right ventricle via anterior cardiac veins. From right ventricle via the right ventricle via the anterior cardiac veins directly into the right atrium, and left ventricles via the coronary sinus. Okay. This is the right coronary artery, this is the left coronary artery. Some percentage of blood flow is collected by the Thebetian valves, which directly open in all chambers of heart. Thebetian valves open in all chambers of the heart, and they open some of the directly open. Okay, so is carried by Thebetian valves, is directly open into all chambers of heart. The resting coronary blood flow is 225 ml per minute. To 25 ml per minute, which is 4 to 5% of the total resting cardiac. So resting coronary blood flow is 225 ml per minute, which is 4 to 5% of total cardiac output, which is 0.7 to 0.8 ml per gram of the heart muscle. 0.7 or 0.8 ml per gram of the heart muscle. 0.7 to 0.8 gram per, ठीक है, 225 ml per minute, 4 to 5% of cardiac output. Oxygen consumption by myocardium. Describe the peculiarities of coronary circulation. Physics changes in the blood flow. During systole, the blood flow will decrease due to compression of the intramuscular. So सिस्टोल में ब्लड फ्लो कम होता है. Compression of the intramuscular vessels, and in diastole. So in systole, the blood flow decreases due to compression of intramuscular vessels. Okay. And in diastole, blood flow increases. Relaxation of ventricles, right ventricular phasic changes are same but less. Diastole means there's relaxation of ventricles, so the intramuscular vessels are not compressed. So in diastole, the blood flow increases in coronary circulation. Is adjusted as per metabolic needs. So what are the peculiarities? One is diastole में blood flow बढ़ता है. Second is my coronary circulation adjusts as per metabolic needs. Myocardial O2 consumption in the heart, there is one capillary approximately for each myocardial fiber. One capillary for each myocardial fiber. One capillary for every myocardial fiber. O2 consumption is proportional to the tension developed by myocardial fibers and the duration of systole. Tension developed and the duration of systole. Major source of energy utilizes free fatty acid. हाँ, anaerobic or ischemic conditions, then only glucose. Oh. Major energy source is free fatty acid. In the heart, the major energy source is free fatty acid. Otherwise, we usually just use anaerobic or ischemic conditions में only then glucose. That coronary circulation changes, phasic changes in blood flow. Diastole में बढ़ता है. It's as per metabolic needs. Third is that it is one capillary for one myocardial fiber, and it depends on the tension developed and the duration of the systole. And major source of energy is free fatty acid, not glucose. Only during ischemic and anaerobic conditions you have glucose being used. Glucose. O2 utilization coefficient is high. Thus, to increase the oxygen supply in the heart, there has to be increase in coronary blood flow. Always high O2 utilization coefficient. अगर you want to increase any of anything, describe arrangement of coronary vessels in different layers of the heart. Why is the subendocardial portion prone to ischemic changes? This is the physiological anatomy of coronary blood flow. ये पूरा आ सकता है as a direct LAQ. Factors affecting it. Special features हो गए. Uh, One is the factors affecting the coronary blood flow. What is angina pectoris? See. Now, anyway, the factors affecting the coronary blood flow. Main determinant of coronary blood flow is myocardial oxygen demand. Factors affecting is myocardial oxygen demand because it is very high utilization coefficient. So, main determinant is the O2 consumption, mean aortic pressure. There is a force for driving blood via coronary artery. Increased mean aortic pressure, more coronary blood flow. तो अगर ज़्यादा mean aortic pressure होगा तो more coronary blood flow. Cardiac output, greater cardiac output, greater coronary blood flow. Metabolic factors increase metabolism of the heart. More cardiac output, more metabolic, more this more oxygen consumption into relative hypoxia. This hypoxia release of adenosine. Adenosine will cause dilation of coronary vessels, increase coronary blood flow effect once. Low K plus in low concentrations will cause dilation of coronaries. अगर K प्लस कम हुआ तो डायलेशन और अगर K प्लस बढ़ा तो डिक्रीज. So K plus is inversely proportional to coronary blood flow. More the K plus, less the coronary blood flow. Nervous stimulation. थायराइड हार्मोन एड्रेनलिन नॉरएड्रेनलिन बढ़ेगा, एक्सरसाइज में बढ़ेगा, टेम्परेचर में बढ़ेगा. So temperature, exercise, thyroid, adrenaline, local and autonomic control of the coronary blood flow. Local and autonomic. The important factor that regulates CBF, local metabolic control of blood flow is well developed in myocardium and is local and metabolic control of blood flow well developed in myocardium and is because of high O2 consumption. Is actually the increased work by the heart, more oxygen, more release of adenosine, degradation of ATP from imagination. Focus. In case CVF is adenosine reabsorbed back in the cardiac cell, lack of oxygen directly causes muscle cell wall relaxation of blood vessel. H plus, bradykinin, CO2, prostaglandins all will cause vasodilation. Metabolic override the effect of nervous. Coronary vasodilator effect. This is a good result. Vasodilator stenosis of coronaries may not cause ischemia. The result will be less if myocardial oxygen consumption is high. and diastolic perfusion of coronaries is less. So there will be a high reserve if myocardial O2 consumption is high. More myocardial O2 consumption. No autonomic controller of coronary vessels, sympathetic and parasympathetic. Sympathetic may direct effect inward coronary vessels and inward norepinephrine act on alpha adrenergic receptors. Okay. Wait, what? Sympathetic will decrease. Damn. Okay, so indirectly sympathetic ज़्यादा बढ़ेगा. Over time, that will only increase. Parasympathetic direct effect. Coronary blood flow is by direct electromagnetic flow meter on the coronary artery, or coronary blood flow is equal to amount of N2O consumed upon AV difference of N2O. Okay. N2O upon AV difference of N2O, that is how coronary blood flow is measured. Now, if इसके applied में ischemic heart disease, coronary heart disease, atherosclerosis, myocardial infarction. Angina pectoris is cardiac pain due to ischemia of the cardiac muscle, that is coronary insufficiency. Pain is felt in the retrosternal. Uh, in pain is felt retrosternal, that is behind, radiating to the left side. So retrosternal pain radiating to the arm on the left hand, referred pain. ठीक है. Hmm. Person suffers from pain on the exertion, that is complete degradation of ATP, produces anginal pain. Effect of myocardial ischemia. Anginal pain is pressing and constricting type. Commonly used vasodilators are nitroglycerin. Other nitrate drugs help relieve pain. Nitroglycerin and nitrate drugs will help relieve pain for, okay, nitrate drugs for angina pectoris. Nitrate drugs and nitroglycerin. What is the pathophysiology of angina pectoris? The most common clinical manifestation of coronary artery disease, it results because of imbalance between myocardial O2 demand and supply. So imbalance of myocardial O2 supply and demand because of mostly atherosclerotic occlusion of the coronaries. Effect of myocardial ischemia, because of ischemia, heart shifts from aerobic to anaerobic, that causes acidosis. Anaerobic excess H plus ions compete with calcium for binding with myosin head. Oh, H plus competes with calcium for myosin head binding, which reduces the heart contractility. So H plus will bind with the calcium. H plus ions will compete with calcium for the contract, which is reducing heart contractility. With the ATP depletion, the calcium reuptake in the sarcoplasmic ligament is affected, which affects the diastolic relaxation of the heart as well. ATP depleted or the calcium reuptake is affected. Calcium reuptake in smooth endoplasmic reticulum, which affects the diastolic relaxation of heart as well. Affects the diastolic relaxation of heart as well. Smoking, hypertension, and hyperlipidemia risk factors for angina. ECG during angina might show ST depression indicative of subendocardial ischemia. And angina में you have ST depression which causes subendocardial ischemia. Subendocardial ischemia. ST depression can show subendocardial ischemia. Explain the physiological basis of treatment of angina. Angina is risk factor, smoking, hypertension, obesity, hyperlipidemia. Educate the patient. Vasodilated nitroglycerin is the drug of choice. If required, long-acting nitrates can be given. Long-acting nitrates can also be given. for angina that is refractory to medicine, surgical interventions, coronary artery bypass graft, or by angioplasty is advised. Coronary artery bypass graft or angioplasty. Surgical interventions like coronary artery bypass graft or angioplasty. Unstable angina can represent as angina that happens at rest or new onset of angina or increase in intensity and frequency of previous angina. ST depression is ECG and cardiac biomarkers are raised. Cardiac biomarkers raised in unstable angina at rest or on new onset of angina or increase in intensity and frequency of previous angina. That's called unstable angina. Increase in intensity of the previous angina. ठीक है. Ischemic heart disease or coronary artery disease is the leading cause of death in the world. Common risk factors are age, male, genetic predisposition, smoking, obesity, physical inactivity, diabetes mellitus, decreased saturated fat in the diet. Decreased saturated fat, increased diabetes mellitus. CBF is acted by atherosclerosis, embolus plaque forming. In the coronary vessel, the occlusion occurs with thrombus, embolus from other areas, spasm from smooth muscle. Atherosclerosis, hardening of blood vessels in the wall are associated with increased cholesterol and TGs. Excess levels of LDL cause atherosclerosis. Increased cholesterol, increased TG, increased LDL, increased cholesterol, and decreased HDL. Deposition of fats. Generation of the LDL cells accumulating between the endothelium and the connective tissue of the blood. LDL will accumulate between endothelium and connective tissue. LDL accumulates between the endothelium and connective tissue. Macrophages ingest the cholesterol to become foam cells. Macrophage will become the foam cell. Smooth muscle cells that are attracted by the macrophage cytokines divide and take up the cholesterol. Foam cells are formed when a lipid core starts accumulating in the intima of the vessel and fibrous scar tissue forms. Intima mein you have lipid core and you will have fibrous scar tissue. Dividing smooth muscle helps to increase the thickness of the intima of the blood vessel and calcification start depositing in the plaque. Calcification will deposit, lipid core goes in intima, calcification start. Collagen exposed from unstable plaques comes in contact with platelet, causes its activation lead to formation of blood clot. So कोलाजन का ब्लड क्लॉट बनेगा. स्ट्रेस टेस्ट ठीक है. मायोकार्डियल इन्फाक्शन. Myocardial infarction is after acute coronary occlusion because of inadequate coronary blood flow इश्चीमिया डेवलप्स अगर सीवीएफ कम है इश्चीमिया होगा. अगर इश्चीमिया होगा then cardiac muscle lose their function permanently, that is they become infarct or dead. Some cardiac muscles lose their functions permanently, that is infarcted or become dead. This is called myocardial infarction. Increase in troponin T, troponin 1, CKMB, creatine kinase. Acute myocardial infarction causes chest pain radiating to the left and excess sweating. Acute myocardial shows ST elevation in ECG. So we saw that this one showed ST depression, apna unstable. Angina pectoris shows ST depression, but in myocardial infarction you have ST elevation. Uh, Coronary angiography tells exact site and extent of obstruction in coronary, or infarct is indicated by prominent Q wave. Prominent Q wave is an old infarct. Complication of myocardial infarction is arrhythmia, hypertension, heart failure, and thromboembolic phenomenon. Arrhythmia, hypertension, heart failure, and thromboembolism. Arrhythmia, hypertension, heart failure, thromboembolism. We have severe chest pain, nausea, sweating, pallor, and tachycardia. ठीक है. चलो. कोरोनरी सर्कुलेशन ठीक है डन. Blood pressure define long-term regulation. The force of circulating blood on the walls of the arteries. Force of circulating blood on the walls of arteries. LTR by RAS. Long-term regulation by RAS is important. Okay, that is easy. Blood pressure में हाँ those three types. Quickly go through it. कि blood pressure में क्या क्या regulation है. Enumerate the mechanisms that regulate BP. You have blood pressure is cardiac output into peripheral हाँ. So BP is equal to CO into TPR. BP is CO times TPR and CO is equal to stroke volume into heart rate. ठीक है. Any factor that changes this will also affect the BP. The role of the mechanism that regulate role of autonomic nervous system. Medulla vasomotor center, reflex mechanism, short-term mechanism, nervous mechanism, intermediate vascular mechanism, capillary fluid shift and stress relaxation. Long-term is RAS, pressure diuresis and natriuresis. Intermediate is capillary fluid shift method and capillary fluid shift stress relaxation. And this is short-term, you have reflex mechanisms or nervous mechanisms. Vasovagal syncope, activation of basal gyrus reflex, activation of chemosensitive vagal fibers in cardiopulmonary region. It's called coronary chemoreflex or basal gyrus reflex. That is activation of coronary chemosensitive vagal fibers. Chemosensitive vagal fibers in the cardiopulmonary region are activated in basal gyrus reflex. Basal gyrus reflex. Basal gyrus reflex कार्डियोपल्मोनरी रीजन में वेगल फाइबर्स कीमोसेंसिटिव एक्टिवेट हुए Vasovagal syncope is fainting when the patient has intense emotional disturbance. Immense stimulation of vasodilator fibers to skeletal muscles at the same time transmitting strong inhibitory signals through vagus to the heart. Fall in blood pressure, blood supply to brain and bradycardia. So visuals are this reflects in strong inhibitory signals through vagus, fall in BP, decreased blood supply to brain, bradycardia, intense emotional disturbance. Carotid sinus syncope is more sensitivity of carotid sinus to compression. Subclavian steel sin ठीक है इतना भी नहीं. Short term mechanism is baroreceptor reflex, chemoreceptor reflex. Short term में baroreceptor CNS ischemic response. So here in short term, you have baroreceptor, chemoreceptor, and the CNS ischemic response. Baroreceptor is located in internal carotid artery above coronary bifurcation called as carotid sinus. Wall of baroreceptors are located in the walls of internal coronary artery. Aortic arch is aortic sinus. So baroreceptors via the vagus nerve will go. Then baroreceptors. Glossopharyngeal nerve and the vagus nerve then goes to nucleus tractus solitarius. Efferent F from the blood vessels and heart. Baroreceptors are spine line. ठीक है. Internal from the carotid artery and the coronary. Internal carotid artery and the wall of aortic arch. So in the carotid sinus and aortic sinus, you have the baroreceptors. ठीक है. Baroreceptors in carotid artery and in the carotid sinus and the aortic sinus. 60 to 180. They maintain mean arterial pressure at 100. They are not stimulated between the range 0 to 60. So there's a carotid body, carotid sinus, vagus. It goes via herring nerve, glossopharyngeal nerve, then goes to nucleus tractus solitarius. Chemoreceptors is also carotid and aortic body. That is body. Chemoreceptors are the carotid aortic bodies and this is carotid and aortic sinus. Fall below 80 mm Hg, that will cause O2 lack, excess CO2. Glossopharyngeal nerve. Center is nucleus tractus solitarius, same as baroreceptor. It is not very powerful controller. Sympathetic nerve. Inhibition of vasoconstrictor area, vasodilation, peripheral resistance, BP normal. Vasodilation of arterioles, vasodilation of veins, excitation of vagus center, inhibition of heart, decrease heart rate, decrease force, decrease myocardial contractility, decrease impulse conduction. BP is normal again. ठीक है. This is short term regulation. This is Bainbridge reflex. CNS ischemic response. Increase CO2 and lactic acid below 50. and causes vasomotor center stimulation, strong sympathetic stimulation. So, kick. That's called arterial reflex. Next, we have circulatory shock. Define ECG. Explain. Explain an ECG. Define the stroke volume, cardiac output, cardiac index, stroke volume index. Stroke volume index. Cardiac output is equal to stroke volume into heart rate. Factors affecting cardiac output are given. Cardiac output is affected by the venous return, decreased thoracic pump, increased end diastolic volume, more venous return, so more preload, more preload, then more cardiac output. Decreased afterload means decreased peripheral resistance. Cardiotonic drugs increase sympathetic activity and decrease ventricular muscle mass will cause more muscle contractility and more heart rate, more cardiac output, venous return, skeletal pump activity, abdominal muscle pump activity, degree of filling of systemic circulation, and decreased resistance. So anemia में the cardiac output is increased. Thyrotoxicosis में there is excess thyroid secretion, decreases peripheral thyrotoxicosis, decreased BMR, decreased peripheral resistance, more cardiac output. ठीक है. Cardiac output is heart rate into stroke volume. So stroke volume can be increased by myocardial contractility and increased end-diastolic volume. More myocardial heart rate is decreased by parasympathetic but increased by sympathetic innervation. Stroke volume can be increased with increased myocardial contractility and increased end-diastolic volume. More myocardial contractility, more end-diastolic volume. अगर ज़्यादा होगा, ADV ज़्यादा होगा, stroke volume आराम से ज़्यादा होगा. More increased venous rhythm, increased cardiac output, abdominal muscle pump, respiratory pump, and venous constriction will increase venous return. That is caused by sympathetic innervation, which also causes increase in myocardial contractility. That also causes an increase in the heart rate. Very nice. ठीक है, कुछ तो लिख सकेंगे यार, इजी है. ठीक है. So blood pressure done, heart rate done, HR heart rate ठीक है done. Factors affecting just the heart rate, इतना पे नहीं आएगा यार. Now circulatory shock, define, classify, compensatory stage of progressive stage, hemorrhagic shock, physiological basis of management. So what is classify different types of shock? What is circulatory shock? What are the different types of circulatory shock? What is the compensatory stage? Progressive stage, hemorrhagic stage. So it is the generalized inadequacy of blood flow throughout the body to the extent that the body gets damaged because of too little delivery of oxygen and nutrients. Inadequacy. You have cardiac types of causes of shock, type of shock. Cardiogenic shock, decreased cardiac output is cardiogenic. Seen in cardiac arrhythmia, failure, valvular heart disease. Decrease in blood volume, that is hypovolumic. So cardiac output is cardiogenic. This is hypovolumic, which is hemorrhagic shock, traumatic shock, excess diarrhea, vomiting, hypovolumic shock. Then decrease in vascular tone, that is non-volumic shock. Neurogenic shock, anaphylactic shock, and septic shock. Neurogenic is brain damage, anesthesia. Anaphylactic is antigen antibody reaction, histamine reaction. Septic shock is due to infection. So neurogenic shock, anaphylactic shock, septic shock, hemorrhagic shock, cardiogenic shock, and obstruction of flow to blood from ventricle. That is called obstructive shock. Now, what are the signs and symptoms of circulatory shock? Decreased blood pressure, that is hypotension. Tachycardia, thus slow, cold skin due to vasoconstriction, decreased velocity of the blood flow, decreased urine output, decreased blood flow to vital organs. Non-progressive or compensatory stage can cause full recovery, less than 10% blood loss. Progressive. So non-progressive or compensatory. Progressive is severe and causes a critical amount more than 40% blood loss. And vicious cycles are set in progressive state of shock. Shock progresses to the extent that all forms of therapy are inadequate to save the person's life. Now, different compensating mechanisms occur in hypervolumic shock. Mm, Long-term mechanism via baroreceptor reflex, sympathetic stimulation, increase venous return, decrease GFR. So if there's moderate loss of blood, it'll cause sympathetic activation. It'll cause fall in blood pressure, baroreceptor effect, chemoreceptor, CNS ischemic response, all short-term mechanisms. Renal ischemia like renin-angiotensin and aldosterone. These will cause all mechanisms to restore BP, ECF, volume, tissue perfusion. Are RAS and aldosterone. RAS will cause vasoconstriction of blood vessels. Fall in tissue perfusion. Fall in blood volume or release of thirsting more water. Now, progressive shock में what are the phases? Cardiac depression, coronary blood flow, VMC failure. तो VMC failure में there's decreased BP तो brain ischemia. It fails to restore BP. Block of small vessels. Decreased blood vessels or decreased tissue formation, sluggish blood flow via microvessels. Lactic acid locally. Increased acidity, ischemia products, activation of blood agglutination, tiny blood clots. Further decreased tissue worsens the shock. Brain BP कम हुआ, brain ischemia हुआ, VMC stimulation, CNS ischemic response, VMC failure. Capillary permeability increases, BP decreases, decreased tissue perfusion. Capillary hypoxia, increased capillary permeability. Release of toxins by ischemic tissue. Histamine, serotonin, and tissue enzymes damages the circulation. Histamine, serotonin, cardiac depression. Endotoxin is released from gram-negative bacteria. Endotoxin from gram-negative causes cardiac depression and further shock. In septic shock, even endotoxin released from gram-negative bacteria. Cellular deterioration, sodium, failure of sodium-potassium pump, decreased mitochondrial activity, release of lysosomes from tissue, deterioration of many organs, liver, lungs, tissue, liver, lungs, and heart tissue necrosis. Decreased tissue perfusion causes necrosis. Acidosis is shock. Tissue necrosis, acidosis, blood acidosis, decreased oxygen metabolism of foodstuffs, and fluid replacement therapy. If the shock is hemorrhage, transfusion of blood. Sympathomimetic drugs will help treatment of circulatory shock. Uh, Mimic and useful in neurogenic and anaphylactic shock. Not useful in hemorrhagic shock. Okay. So dextrins can be used. Mean arterial blood pressure. Connecting CNS ischemic response. Okay.
Pressure and venous resistance. A decrease.
Preload contractility after load. Pathogenic. So we saw that coronary blood flow is special. It doesn't require any diastole blood flow increases one capillary for each myocardial tissue. Major sources free fatty acid. Depends on the metabolic needs. Uh, Decreased. CVS done. अभी के लिए we're done with. तो रीनल सीवीएस अभी के लिए हो गया आई गेस. रेस्पिरेटरी कर लेंगे. रिप्रोडक्टिव ऑल्सो डन. सीवीएस डन, रिप्रोडक्टिव डन. नाउ रीनल, रेस्पिरेटरी, न्यूरो एंड एटकॉम. चल न्यूरो, एटकॉम, न्यूरो एटकॉम. एटकॉम, हाँ एटकॉम का इसका पीरियड देखना पड़ेगा. एटकॉम. We have एटकॉम कौन सा है? What does it mean to be a patient? I know. Yeah. What does it mean to be a patient? So internal assessment 2, respiratory physio, reproductive physio, endocrine. ठीक है, अभी के लिए CVS डन. कॉम खत्म कर लिया. We will see. By the way, a balanced approach to patient care requires an understanding patient, their illnesses, concept of suffering, coping mechanisms, role of the doctor. Sufferings, coping mechanisms. What is the role of the doctor? Empathy versus equanimity, and the difference between healing and curing. Enumerate the roles of a physician and demonstrate empathy in patient encounters. So, what's the symptom? Physician empathetic, need to be skilled, competently perform the surgery, make a diagnosis, honest, unbiased, professional, focused, determined. ठीक है. Professional qualities of physician: intellect, practices ethical knowledge, professional conduct, avoid publicity, growth of the medical profession, communication skills, altruism. So empathy and entire respiratory physiology. So respiratory में क्या क्या आएगा? Let's see. Oxygen, hemoglobin, dissociation curve, draw label factors affecting Bohr's effect, shift to right. What is P50? Roll of 2-3 BPG. 90% seen, 99% seen at 80 mmHg. PCO2, pH, BPG, Bohr's effect, right shift in tissues. P50 is BO2 50% saturation. BPG increases in hypoxia, facilitates release of oxygen. Now, characteristics of pulmonary circulation. It's a short circulation, 1/3 thickness of aorta. So pulmonary means it has 1/3 pulmonary trunk has 1/3 the thickness of aorta. It has huge compliance. ठीक है, pulmonary circulation में huge compliance. Bronchial vessels 0 to 25 mmHg, correct. 8 to 25, ठीक है, 0 to 25 mmHg. Systole, correct. 0 to 25 is the range. 1/3 the thickness of aorta. They are short. Alveolar vessels constrict if oxygen is low. Systemic में it dilates. Alveolar vessels constrict when oxygen is low. Okay. The vessels will constrict if oxygen is low. More blood flow going from the top to the bottom of lung, 3 zones. Now acclimatization to high altitude, enumerate physiological changes. Significance of changes: increased ventilation, RBCs, diffusing capacity, angiogenesis, ability to use oxygen. No, we should do acclimatization actually. Now coming to acclimatization. Acclimatization, long-term exposure to hypoxia, such as a person living long-term exposure to hypoxia, person living at sea level. This is long-term changes when you are living at sea level and goes to high altitude for a long time. Person gradually gets acclimatized. Various compensatory mechanisms changes during acclimatization. ठीक है. There's increase in pulmonary ventilation, increase immediate compensation for high altitude is increase in pulmonary ventilation to hypoxic stimulation of peripheral chemoreceptors. This rise is only 65% above normal. Pulmonary ventilation बढ़ेगा due to the because of braking effect of CO2 on action of decreased PO2. When a person stays at high altitude for many days, there's a gradual increase in ventilation to an average of about 5 times the normal. This is because of loss of braking effect of CO2 due to renal correction of alkalosis, leading to decreased bicarbonate in CSF and brain tissue. So there will be decreased. There will be 5 times normal the amount of pulmonary ventilation over a long period of time because of CO2 braking effect not being present because of respiratory alkalosis and all taken care of. Alkalosis is corrected because of decreased bicarbonate ion concentration in the CSF and brain tissue. In permanent high altitude residents, there's maximum voluntary ventilation and diffusing capacity. Increase in RBC and hemoglobin. Hypoxia stimulates secretion of erythropoietin. More erythropoietin, more RBCs, more hemoglobin, which increases the RBC production. Increasing number of circulating RBCs. This is to increase in hematocrit value from 45 to 60 in full acclimation. Hematocrit goes till 60% because of more RBCs, and it causes concentration of hemoglobin to rise. Then increase in blood volume. So increased pulmonary ventilation, increased cardiac out. No, decreased pulmonary ventilation, decreased more correction of alkalosis, more erythropoietin, more blood volume, increase in the diffusing capacity of lungs. Expense increase the heart rate and force of contraction. That causes the cardiac output to become 30% to compensate for hypoxia. BP remains normal, cardiac output, heart rate, and force remains increased. Shift of auto dissociation curve. So more mitochondria, more mitochondria बड़ा, angiogenesis बड़ा, capillary density बड़ा, blood volume is increased. So pulmonary ventilation increases, hypoxic stimulation ज़्यादा है, 5 times the normal, loss of braking effect, increase in blood volume, more hematocrit, more angiogenesis, more in diffusing capacity of lungs, increase in heart rate, increase in force of contraction, same BP. O2 dissociation curve right में shift होता है, more unloading, more capillary density, more angiogenesis. This is all occurring during acclimatization. More angiogenesis, more acclimatization, more mitochondrial oxidative enzyme systems are plentiful which can use the oxygen effectively. ठीक है, इतना बस हो गया acclimatization के लिए. ठीक है, this is Heart stroke. Stroke is what is heat stroke? Heat stroke is exertional or non-exertional. Temperature above 40 degrees, then there is CNS dysfunction. During heat stroke, there's heat exposure, excessive fluid loss, failure of regulatory mechanism. C in heat exposure, fluid loss बढ़ेगा more. There will be CNS dysfunction. It can be exertional or non-exertional heat stroke. Failure of regulatory mechanism causes hemorrhage. CNS is affected, treated by evaporative cooling and prevents hypothermia.
I recently had a patient come into the hospital who was brought in by ambulance for confusion. It was altered and was really hard to pick up. And it turns out that it wasn't the patient who called. Was 68 years old. It turns out it was really warm outside that day, and this guy was covered in thick blankets. Additionally, this guy's temperature was a whopping 105 degrees Fahrenheit. So, does diagnosis come to anyone's mind at this point? This guy was in heat stroke. This diagnosis carries a mortality rate ranging from 21 to 63%. That's really high. Heat stroke is defined as a core body temperature greater than 40 degrees Celsius. That's greater than 104 degrees Fahrenheit. It is also often accompanied with CNS dysfunction. What I'm talking about here is that the patient with heat stroke typically complain of weakness. If not, they're confused, irritable, lethargic, delirious. You get the point. With heat stroke, there's usually some sort of high level or cognitive dysfunction. The last thing that's required for the diagnosis of heat stroke is the presence or exposure of a patient to a large heat load, typically in a setting where heat from the person can be dissipated. In this case, a patient was covered in blankets, which probably limited his ability to let off some of that heat. Now let's take a step back and break this down further. There's two types of heat strokes. There's your classic heat stroke, which is also known as non-exertional heat stroke, and then there's exertional heat stroke. Now, the main differences between these two is that in exertional heat stroke, your patient population is often younger and otherwise healthy, meaning that these patients typically don't have any chronic medical conditions and they're not taking any medications. On the other hand, classic heat stroke usually happens in people who are older with chronic medical conditions. These people are often taking different medications that may interfere with the dissipation of heat from their body. So if I told you that this patient was 68 years old, was an alcoholic, and also had a history of polysubstance abuse, and that we found cocaine positive in his urine toxicology screen, then you probably guess that this guy is suffering from the classic version of heat stroke. So what are you going to do next? Are you just going to let this guy burn up, smolder, and turn to ashes? Well, probably not. There are different ways to manage a patient with heat stroke, but the most practical way would probably be ice packs and evaporative cooling. We're talking about spraying mists of water on the naked patient and having fans blow air by to facilitate the cooling. This way of cooling has actually been shown to reduce morbidity and mortality in patients with classic heat stroke. Other ways to cool people are with ice packs. We put these ice packs in the person's groin, armpit, and neck, mostly because this is where the major blood vessels run close to the skin. Of course, you can always combine these two ways of cooling to get faster and maybe more efficient results, but you also don't want to cool these patients too fast and cause hypothermia. You really want to stop cooling these patients when the temperature reaches somewhere between 38 and 39 degrees Celsius in order to reduce the overshoot and cause hypothermia. That's because, just as hypothermia and heat stroke is bad for the body, so is hypothermia.
That's heat stroke. ठीक है, exertional loss. Now heat loss. सब किधर था? So we can talk about heat stroke. हाँ. I'll eat something. god. 6 o'clock. Hi Shakti. Nice positive manifestation, you're right. Now what is heat loss? Heat loss is mechanism of sweating. ये सब किधर था भाई? Let's take a break. Even I'm getting totally saturated. Just read the comment. Day one of rebuilding myself. देखते ही देखते वक्त कैसे गया. True. That's why every day counts. But since I started streaming, I don't know, the days just seem slower, which is very nice actually. Because we because I'm on stream for so long and I start my day so early, like the day just seems longer. Like the perception of each day has just become bigger, which is good actually. Like I feel like I have more time. You make your day long too. 3 Riyas. गुड मॉर्निंग. भूल गई मॉर्निंग में आना. यूट्यूब ओपन किया आज 1:30 AM. बाप रे. Salt analysis you prepared doesn't have group 1 and 2 katans on. नहीं है ना. Of course you have to do it. Probably I may not have uploaded it, but I've definitely made notes for it. Completed revising chemical bonding. Good. Shakti, like mentally you're preparing for 26 or 25, like. Did you study S block? Okay. Honestly, I did. You know now how I don't leave anything unturned. But don't do it. Not necessary. Not required. I just read it. I didn't study it. I did S block. I read hydrogen. I think I read them. But I read S block. S block is relevant. But the P block mein many things are covered also in P block. But not in depth. Like we just went through it once with my friend, highlighted what was important, and then maybe once skimmed through the highlighted points. Bus. Didn't study it or didn't. I don't think I made an LMR also. But I definitely skimmed through it. Even hydrogen, I skimmed through it. I didn't leave much, honestly. I've never faced academic failure in my life, but I will. How to rise from setbacks. Honestly, same. Like I also never faced academic failure. Then first time we faced me, I got low marks. Cause that's because I didn't study also. But now I want to overcome that. So setbacks just, I guess, decide your goal, work hard towards it. That's the easiest answer. That's what I'm also doing, Abhi. Mentally, don't get affected by it. Ki, you've never got such low marks, but you're getting it. That's fine. Like you can't always be at the top, so it's okay sometimes. But it's important to maintain where you're at. At least not fall too much to a point where you'll feel guilty. That basically. I slept 11, woke up at 4:30 exact. Nice. वो तो शक्ति और पक्का preparing for 26 only क्या? Every setback is a setup for comeback. But why don't you try giving your best for a B25? Just you prepare 26, but जितना हो सके give your best for 25. Every setback is the life setup. Yes, for sure. Agreed. क्या करूँ? I think I'll sleep for a bit. I'm tired. करना है पढ़ाई बट थक गया हूँ. I'll sleep for a bit. I'm gonna be updating every single day till 26. Good, good. Preptil and Shakti all can keep each other accountable. You all are in kind of a similar situation. You all are both extremely motivated for 2026. So today I'll stream early. Yaar. Last call I started very late. Today I'll start early. इसमें my friend is coming. हाँ, हो जाएगा early हो जाएगा. Okay, chalo, focus. Transfer of CO2 is easy. Response of body when the extreme cold. Hypothermia होता है. Use of induced hypothermia, ability to regulate below 75 degrees. CNS depression causes inability to perform heat control mechanisms. Chemical heat production decreases. Gangrene and coma. Induced hypothermia using sedative. Using sedative and cold to stop the heart during surgery. Effect of exercise on respiration. What is VO2 max? Anticipatory response. Neurogenic signals from brain as soon as muscles start exercising. If change not enough, then chemical simulation further changes ventilation. PO2, PCO2 remain almost normal. Increase in ventilation about 20-fold. V is volume, O2 is oxygen, maximum consumption. It is a maximum rate of consumption of oxygen by the body in incremental exercise. Maximal rate of consumption of oxygen by the body. Work of breathing, applied importance, emulate muscles of respiration against three forces: compliance, elastic work, and tissue resistance. Work, airway resistance work becomes limiting to heavy exercise. Internal innermost intercostals, abdomen, sternocleidomastoid, serratus anterior, and scaly. Functional residual capacitance का physiological significance. Keeps the small airways open, prevents collapse of the lungs, and cancels out the elastic forces. Functional residual capacity will cancel out the elastic forces. Now coming to acclimatization to high altitude. Various changes: acute mountain sickness. Acute mountain sickness. Ascending mountains slowly desensitizes the respiratory center. The changes in CO2, thus decreased CO2 does not inhibit respiration. Ventilation increases 400% instead of 70% if ascended in few hours, as decreased O2 is more potent stimulator. Acute mountain sickness occurs in rapid descent. Cerebral and pulmonary edema. Cerebral pulmonary edema. Cerebral due to vasodilation due to hypoxia. Immediate treatment is necessary. It can cause brain damage also. Haldane effect is Bohr related to oxygen, Haldane related to CO2. Bohr, so O, so oxygen, Haldane is CO2. ठीक है. Role of hypothalamus in temperature regulation. Pre-optic anterior hypothalamic area. So how is hypothalamus regulating? Pre-optic anterior hypothalamic area, which is sensitive to temperature changes. 2 hours. Man. I think I'll just skip. No point doing like. I'm ending the stream.